Nursing care of clients with burns, Part 1. The skin is the largest organ in the body, representing about 16% of the adult body weight. Burns are injuries to tissues caused by heat, friction, electricity, radiation, or chemicals. Burns may be caused by even a brief encounter with heat that is greater than 120 degrees Fahrenheit or 49 degrees Celsius. The infection is the leading cause of death in major burn clients. The damaged and dead tissue acts as a nidus for infection. Burn wounds will almost always be infected by microorganisms within 24 to 48 hours. There may be, in addition, a bacterium or septicemia. Bacteremia is a common cause of fatality in severe burns. This transfer of energy from the source of the heat causes physiological changes and damages to the tissues. The most important thing to do when someone is burned is to stop the burning process. If the burn is a heat or thermal burn, immerse or run cool water over the burn. Do not apply ointments to fresh burns, as they may trap the heat in the burned tissue. Factors associated with burns include age, especially children and older adults, careless smoking, alcohol or drug intoxication, physical and or mental disabilities, and certain occupations. Coordinated national prevention programs have focused on child-resistant lighters, tap water anti-scald devices, stricter building codes, having smoke detectors, and fire and burn safety education curriculum for schools. As a nurse, you can advocate for and teach about burn risk reduction strategies in the home and at work. The focus of burn prevention has shifted to educating people in vulnerable communities to identify the hazards and provide first aid. Therefore, you see in this picture a campaign that was started to alert the community about the risk of children under the age of 5 who are likely to be severely injured by hot liquids. So we had to make that association between hot liquids and burns for this population. Types of burns. Thermal burns caused by flame, scalding, or contact with hot objects are the most common types of burn injury. The severity of the injury depends on the temperature of the burning agent and the duration of contact time. Scald injuries often occur in the bathroom and kitchens. Flash, flame, or contact burns can occur while cooking, smoking, or burning leaves in the backyard. Chemical burns are the result of contact with acids, alkalis, and organic compounds. We'll talk more about these on another slide. And then we have electrical burns, and they result from intense heat generated from an electric current. And finally, we have radiation burn, which typically refers to sunburns that result from overexposure to the sun or other ultraviolet light sources that can exceed the ability of the body's protective pigment, melanin, to protect the skin. A serious sunburn can be as serious as a thermal burn and may even have some of the same systemic effects such as blistering, edema, and fever. This slide reminds us of the various types of burns that we can encounter. So again, we have the flame burns, scald burns, which are a type of thermal burn. We have electrical burns and chemical burns, as well as radiation burns. Chemical burns result from direct skin contact with acid or alkaline agents, and the agents destroy tissue protein. It's important to remove the chemical from the skin and then follow that with lavaging with copious amounts of water or saline solution for approximately 20 minutes to 2 hours after the exposure. In addition to skin damage, eyes can be injured if splashed. Acids are found in the home and at work. And then for alkali burns, they can even be more difficult to manage than acid burns, since alkalis adhere to tissue, causing protein hydrolysis and melting. Organic compounds, especially things like petroleum products, can produce contact burns and systemic toxicity, causing liver and kidney damage. Electrical burns result from intense heat generated from an electric current. Direct damage to nerves and vessels, causing tissue anoxia and death, can occur. The severity of an electrical injury depends on the amount of voltage and the tissue resistance. Tissue densities offer various amounts of resistance to electric current. For example, fat and bone offer the most resistance. Nerves and blood vessels offer the least resistance. And the current that passes through vital organs produces more life-threatening sequelae than that which passes through other tissues. Certainly, electrical injury produces heat coagulation of the blood supply and the contact area as electric current passes through the skin. Electrical injury puts the patient at risk for dysrhythmias or cardiac arrest, severe metabolic acidosis, and myoglobinuria. The electric shock can cause immediate heart standstill or ventricular fibrillation. Delayed dysrhythmias or arrest can occur without warning during the first 24 hours after injury. Whenever massive muscle and blood vessel damage occurs, myoglobin from injured muscle and hemoglobin from damaged red blood cells are released into the circulation. The myoglobin travels to the kidneys and can block the renal tubules. This can result in acute tubular necrosis and acute kidney injury. With direct current, as occurs with a lightning strike, we have both an entry and exit wound and a flash over the skin, which can mean less internal damage. Finally, on this slide, we talk a little bit about radiation burns. Typically, this is from a sunburn, but may occur as a result of radiation treatments that accompany cancer therapy. In this case, radiation burns leave the skin intact, and so all the functions that the skin provides are left intact. Let's look at some injuries caused by electrical burns. As we said, an electrical burn causes tissue damage from intense heat. generated by the electrical current passing through the tissue, including muscle contractions that are strong enough to fracture long bones and vertebrae. Myoglobin is released into the circulation when massive muscle damage occurs. On the picture, in the left side of the slide, we see a contact electrical burn. The knee on the left was energized. That would be the entry wound. And the knee on the right was grounded, so we have the exit wound. There have been cases where an arm or leg is severely burned by high voltage electrical current to the point of coming off, and the victim is not electrocuted. In these cases, the current passes through only a part of the limb before it goes out of the body and into another conductor, like the ground. Therefore, the current does not go through the chest area and may not cause death, even though the victim is severely disfigured. If the current does go through the chest, the person will almost surely be electrocuted. A large number of serious electrical injuries involve current passing from the hands to the feet. Such a path involves both the heart and lungs. This type of electrical shock is often fatal. Okay, let's see if you've been paying attention. Here's an NCLEX style test question. Which type of burn injury would cause myoglobinuria, long bone fractures, dysrhythmias, and/or cardiac arrest? Hopefully you chose B. Electrical burn injury can result in all of those things that we just mentioned in the stem of this question. Very good. This is a select all that apply NCLEX style question. Which characteristics accurately describe chemical burns? Hopefully you were able to select D and E. Chemical burns. Lavaging with large amounts of water is important to stop the burning process with these injuries. Alkaline substances that cause these burns continue to cause tissue damage even after being neutralized. Burn injury involves the destruction of the integumentary system. We can classify burns according to the depth of the burn injury. One system defines an injury by degrees as first, second, and third degree burns. The American Burn Association recommends a more precise definition and classifies burns according to depth of skin destruction. Here we see the epidermis, which is the outer portion of the skin, and then we see the dermis, also called the basal layer of skin, which contains the blood and lymphatic vessels, nerves, glands, and hair follicles. And then we also have the subcutaneous layer, which includes, again, subcutaneous fat, blood vessels, and nerves, and hair follicles as well. Let's look at the classification of burns determined by tissue damage. First-degree burns are also called superficial burns, and they can also be called minor burns. The burn area is painful, the outer skin is reddened, and there is slight swelling. Second-degree burns also are called partial thickness burns or moderate burns. The burned area is painful, the underskin is affected, and blisters may form. The area may have a wet, shiny appearance because of exposed tissue. Third-degree burns are also called full thickness burns or critical burns. Here, the area is insensitive due to the destruction of nerve endings. The skin is destroyed. Muscle, tissues, and bone underneath may be damaged. With a critical burn, the area may appear as charred, white, or grayish in color. The skin in this area may also be described as leather-like. As far as classifying burns, we see it here in this diagram summarized are superficial, partial thickness, and full thickness burns based on the depth of the injury. Superficial or first-degree burns only involve the epidermal layer of the skin. Typical causes are sunburn, ultraviolet light, and mild radiation burns. Appearance of the skin is pink to bright red. There may be some slight swelling, and it is mildly painful. The usual treatment involves a mild analgesic and application of water-soluble lotions. They will usually heal by themselves without scarring within a few days. The extensive burns, even if they're superficial burns, if they are on the very young or the very old, or if the person begins to feel ill, they should be seen by a healthcare provider. A second-degree burn involves redness, swelling, and blistering, and the damage may extend beneath the epidermis to the deeper layers of the skin called the dermis. Now, second-degree burns can be further classified as superficial partial thickness burns or deep partial thickness burns, depending on the depth of the burn through the layers of the dermis. Causes of superficial burns are brief exposures to flash flame or hot surfaces. The deeper partial thickness burns can result from exposure to hot liquids or solids, and also to chemical agents or direct flame. Blistering from a second-degree burn may appear differently depending on the depth of the injury. A superficial second-degree burn can present with blisters that are bright red and very moist and glistening. A deep partial thickness burn can have blisters that appear pale and waxy. There is severe pain associated with second-degree burns, especially when in contact with the air or heat. The usual treatment involves analgesia, but may involve skin substitutes, especially with our deeper partial thickness burns. Grafting may be necessary. The second-degree burn involves the deeper layer of the skin called the dermis. The skin will be blistered and may look moist or mottled. They are intensely painful. With good care, they will heal with little scarring in about 3 weeks. These burns should be seen by a healthcare provider if they are over 10% of the body surface area, if they encircle a body part, or if pain control is needed. Young children, senior citizens, and ill patients should be seen by a healthcare provider when they have a second-degree burn. Third-degree burns are full thickness burns of the skin. The damage may extend into tissues below the skin surface. These burns look charred and blackened with areas of red and white within them. All third-degree burns should be evaluated by a professional healthcare provider. Third-degree burns may also appear white or gray and leather-like. And the burned area, the actual area, is insensitive. That's because the nerve endings have been burned and are no longer there. So at that exact site, the patient cannot feel pain. Other burns which should be seen by healthcare providers include any burn to the face, because that indicates it may be impacting their breathing. Also burns to the genitals, to the hands and the feet. Okay, all of these should be seen by a healthcare provider, because when there is burned injury to the hands, feet, or genitals, there is a risk of loss of function. And a loss of function is a medical emergency. We want to make sure to prevent that. So burns to the face may affect breathing, while burns to the hands and feet may cause loss of function. Full thickness burns, or third-degree burns, involve all three layers of the skin. We see the damage to the nerve endings, and so in this very location, there is no pain here. However, notice that a third-degree burn is surrounded by tissue that is blistered, or second-degree burns out here. These still have nerve endings. So even though a person has a third-degree burn, they still have lots of pain associated with their burn. Okay, notice with the third-degree burn, there's no blisters, there's no bleeding, there's little pain, and it appears white and leather-like in this picture. So appearance can look different depending on the actual burn or the third-degree burn. The usual treatment for third-degree burns is skin grafting. A skin graft is a surgical procedure in which a piece of skin from one area of the patient's body is transplanted to another area of the body. Permanent skin coverage is the primary goal for burn wound care. They are usually performed in a hospital under general anesthesia. The time for healing may be 6 weeks or even a few months. But within 36 hours of the surgery, new blood vessels will begin to grow from the recipient area into the transplanted skin. And we also have skin from another person or animal may be used, but it's only going to be a temporary cover and used for large burn areas to decrease fluid losses. And we have some examples there as TransCyte and Apligraf as temporary skin substitutes. It's very important during this time that we leave the limb or the transplanted area alone so that the graft can take. Additional movement would not promote the new growth of blood vessels and into the recipient area. So it's important to leave it alone and not do too much with the graft area while it is healing. When assessing a patient's full thickness burn injury during the emergent phase, what would the nurse expect to find? Answer would be A. Dry, waxy, white, leathery, or hard skin is characteristic of full thickness burns in the emergent phase, and it may turn brown and dry in the acute phase. Which of the following types of burns will not require skin grafting? And again, the answer is A. You would not need to graft with a small partial thickness burn. A method of permanent burn wound closure is and hopefully you chose C, an autograft. The only permanent method is the autograft. This is a select all that apply question. A client returns from the operating room with a partial thickness skin graft on her left arm. The donor tissue was taken from her left hip. In planning her immediate postoperative care, which of the following interventions should the nurse include? Hopefully you selected B, C, and E. The left arm should be elevated to reduce edema. Complete rest of the arm is needed to allow the graft to adhere. The donor site is usually more painful than the graft site, and the client will require pain medication to obtain relief. Because adequate circulation is needed for graft healing, it's important to monitor for pulse presence. Changing the dressing every 8 hours, performing range of motion exercises, and ambulating are inappropriate because postoperative graft sites require immobilization for 3 to 5 days. The treatment of burns is related to the severity of the injury. The severity is determined by the depth of the burn, but also the extent of the burn calculated in percent of total body surface area. One common tool for determining the total body surface area affected or the extent of the burn wound is the rule of nines. The rule of nines is often used for initial assessment of a burn patient because it is easy to remember. Healthcare workers use the rule of nines to determine the percentage of body surface area affected in patients who are more than 9 years old. Each arm with its hand is 9% of body surface area. Okay, so each arm, both front and back, is 9% of body surface area. If they only mentioned the front of an arm, then it would be half of 9%, or somewhere between 4 and 5%. Remember that this is an estimate. Each leg with its foot is 18%. So that would mean only the front of the leg would be half of 18 or 9%. But the entire leg and foot, both front and back, would represent 18% of the total body surface area. The back of the torso, including the buttocks, is 18%. The head and neck are 9%. And the genital area is 1%. Okay, so this rule cannot be applied to young children because their body proportions are different. So with young children, we will use the body surface area based on the palm of the patient's hand as a measure of 1% area. Become familiar with the use of the rule of nines so that you can apply it to a question such as this. An adult client was burned severely in an industrial accident. He has second-degree burns on his right leg and arm and on his back. He has third-degree burns on his left arm. The triage nurse, using the rule of nines, estimates the extent of the client's burns as what percentage? Okay, we should get a grand total of 54%. Here we have another example of a rule of nines question. A patient has the following mixed deep, partial thickness, and full thickness burn injuries: face, anterior neck, right anterior trunk, and anterior surfaces of the right arm and lower leg. According to the rule of nines, what is the extent of the patient's burns? Hopefully you arrived at the answer of 22.5% total body surface area. Okay, another question here. Is it possible to determine the actual extent and depth of burn injury during the emergent phase of the burn? Why or why not? And the answer is no, it is not, because edema and inflammation obscure the demarcation of the zones of injury. Let's discuss the process of healing. The first step in the process of healing is hemostasis, which involves platelet aggregation and thrombus formation. The wound is walled off. The next step is inflammation. This is an acute local inflammatory response, which involves local vasodilation and increased capillary permeability. And then we have proliferation, which is the formation of granulation tissue. And finally, we have remodeling, which means we have the reorganization of collagen fibers and the scar contracts. Granulation tissue is the goal. The goal is to have the whole wound look like a raw hamburger, which is what we see in this picture here. So this is an indication that the wound is healing properly. It's going to be very important that we prevent complications like infection. Okay, so we're going to talk a little bit more about caring for this wound. Moderate burns may heal in 10 to 14 days and may leave scarring. Critical or major burns take more than 14 days to heal and will leave significant scarring. Scar tissue may limit mobility and functionality. However, physical therapy may overcome some of these limitations. In other cases, additional surgery may be advisable to remove scar tissue and restore appearance. There are two types of excessive scarring. There is a hypertrophic scarring characterized by overgrowth of dermal tissue, but the tissue remains within the boundaries of the wound. And then the other type of excessive scarring is called keloid formation. And in this case, the scar extends beyond the boundaries of the wound. A method of permanent wound closure is, and I think this may be a repeat, but it is an autograft. That is the only method for permanent burn wound closure. Okay, prevention of contractures and scarring. After severe burn injury, scars are developed in the course of wound healing. Scars often become not only aesthetic, but also have functional problems. Scar contractures on the joint regulate smooth joint movement. And in children, it can result in growth impairment of the tissues. That it is important to decide what treatment should be selected and how to prevent scar contractures in acute stage of burn. So physical therapy is very important with correct positioning. They'll make use of splints to maintain flexion, except not during exercise, of course. And they're also going to promote early ambulation and range of motion, whether passive or active, every 2 hours to prevent scar contractures on the joints. Also, they will be in touch with people who will make custom support garments for them, and using these tubular support bandages can help to reduce the occurrence of hypertrophic scarring. A few words about pre-hospital management. First of all, remember to stop the burning process to limit the severity of the burn. In addition, we need to support vital functions of the burn victim and perform CPR if indicated. Note any other injuries. Initiate fluid replacement and cover the client. Thermal burns, typically we respond by having the patient or a client stop, drop, and roll to control fire. Also wash the area with water, cool water, but no ice, because that will just further cause further tissue injury. And cover them really to prevent hypothermia and to prevent debris from getting into the open wound. Chemical burns are going to necessitate removing the clothing and also lavaging with water. Also, in the emergency room as well, you may need to contact Poison Control Center. Sometimes it is necessary to find out about a specific chemical or type of burn and the best way to treat and follow that patient's care. Pre-hospital care for electrical burns. Before electrical burns are treated at the site of the accident, the power source must be disconnected if possible, and the victim moved away from it to keep the person giving aid from being electrocuted. Life-saving measures again take priority over burn treatment, so breathing must be checked and assisted if necessary. Electrical burns should be loosely covered with sterile gauze pads and the person taken to the hospital for further treatment. When dealing with radiation burns, we can prevent or minimize exposure to radiation by shielding, distancing, and limiting the amount of time that an individual is exposed to the radioactive source. The severity of the burn will determine where the burn patient should receive treatment. Who should be seen in the intensive care burn unit? Well, those who have a first or second degree burn that covers more than 25% of their body, those who have third degree burns on more than 10% of their body, and anyone with a burn involving the hands, feet, face, eyes, ears, or genitals should be seen in the burn ICU. Those who have associated injuries, for example, bone fractures or smoke inhalation, should go to the burn ICU. Other factors influence the level of treatment needed, such as the presence of a chronic disease. Also, children and elderly are more vulnerable to complications from burn injuries and require more intensive care. Note the burn unit nurse taking care of the burn patient, performing passive range of motion exercises. Also, completely gowned up for the protection of the patient who has open burn wounds. Well, minor burns, again, are not going to disrupt the skin. So they are not associated with immunosuppression or increased risk of infection. Their care is rather simple, washing with mild soap and water, perhaps giving a tetanus shot if needed, and taking care of the wound with just topical agents and dressings. There's not much. They can go home and take care of it at home, and they can, go to their appointments on their own. So we're not going to spend much time on this aspect of these minor burns, but we're going to be very much interested in looking at the patients who have major burns. And that will be coming up on our next part of this presentation. We will continue with the care of clients with major burns. See you there.